What we're really going to spend today's session on is kind of really the nuts and bolts of serology. So we've actually broken this session into really two parts, kind of serology 101, and then kind of reiterating some of the stuff that we learned today in the next session. And the reason we have designed it this way is that I think that for a lot of providers who are trying to really develop a capacity to not only start with screening for hepatitis B, but then move into management. The serologies are a place that are daunting, confusing, and so we really want to take a deeper dive over this session and the next to really talk about serologies. And based on the first polling question, it looks like this is an area where, practically speaking, hopefully a lot of you will gain some confidence at the end. But let's see. All right, so serology part one. And we're going to kind of go back to the case that we used in the first session, and it's okay if you weren't here for the first session of this module. But this was Yuen Lee. She was a 28-year-old woman who was born in the United States. Her parents were born in Taiwan and moved to the United States a couple of years before she was born here. Yuen met with her primary care physician to discuss family planning, and she initially was reluctant or resistant to really having hepatitis B screening, but she ultimately consented after we optimized the conversation around hepatitis B and why it's important to get tested. And part of that discussion included consequences of untreated infection and discussion of the CDC guidance or guidelines for screening. And so the next question after you've thought about, oh yes, this is somebody who we should be engaging a conversation around hepatitis B screening and offering the test, the next question is, what test do you order? And that's what we're going to spend part of today really discussing. So really the hallmark of screening is accomplished by the following tests. The first test is the hepatitis B surface antigen. And this is a really critical test in screening because it's really the test that tells us whether or not somebody's infected. So it's a marker of active infection. And if it's positive for at least 6 months, it meets the definition of chronic hepatitis B. Now in clinical practice, we often are not always checking it 6 months apart, but really based on kind of the potential risk factors somebody might have. And we spent some time talking about those risk factors in the last session, which include parents being born in an area of high endemicity for hepatitis B infection. That would be a reason to be, offering the screening in this scenario. So hepatitis B surface antigen, really critical test here in screening. The next test is hepatitis B surface antibody. And this is really a marker of immunity to hepatitis B. What it doesn't tell us is if you're immune because you've been infected before and then you were lucky enough to clear it and develop immunity, or if you developed immunity due to vaccination. But the presence of the surface antibody is a marker that tells us, and if let's say that's the only test that you have on a patient, that indicates this person is immune from one of two mechanisms possible. The third test is the hepatitis B core antibody. And this is a total antibody, what we call an IgG version of an antibody. And what it tells us, and we'll talk about this a little bit more, is that this is a person who's actually been exposed to the virus in the past, okay? Or we'll talk about kind of the less common potential interpretations of this test. There could be a false positive, and the scenario in which you want to think about this, which we'll talk about in another slide, is if it's the only test that comes back positive out of these three, okay? And then we added one extra bullet here at the end. If in any scenario you're ever really suspicious of acute infection with hepatitis B, and we talked in the last session that for the vast majority of patients, 65 to 70%, do not have any symptoms associated with their infection. Particularly because the most common route of transmission is mother to child worldwide, and that's a silent period in terms of acquiring the infection for most people. So you might see this more commonly in adult patients who come in with a viral prodrome, might come in deeply jaundiced. You might check liver tests. Liver tests are elevated, and you're thinking, okay, what other things should I be working this patient up for? Hepatitis B and acute hepatitis B is something to consider. And for that, there's a very specific test, and that's the core antibody to hepatitis B, but it's the IgM. Okay, the IgM is the acute immune marker that becomes positive typically before the IgG is formed. Okay, so if you're thinking about acute hepatitis B infection, the one most important test is the core IgM antibody. All right, so now let's say you check those screening tests and the hepatitis B surface antigen comes back reactive or positive. That indicates that that person has active infection, as we just mentioned on the slide before. So that should actually trigger the following tests to be checked. And these tests include the hepatitis B E antigen, and this is a surrogate marker of high viral load. It also is typically seen in the earlier kind of time period of having this infection, usually within the first 20 years or so. The second test is the E antibody to hepatitis B. And this is typically associated kind of with having this infection for a longer period of time, which then also is associated with a lower hepatitis B DNA PCR viral load. And so these are two additional serological markers that in anybody who is surface antigen positive or has active infection, we want to check some additional serologies. And why this is really important is that these serologies are used to help make the decision about how to manage them. And what we specifically mean here is who needs treatment potentially earlier or now versus who can wait. Now, that decision is not made just based on these two additional serology markers. We're going to talk about this in the fourth session, really how we take all of these test results and synthesize them and put them together in order for us to come up with a management plan that may or may not include treatment now. The third test to think about after the surface antigen is positive, in addition to the hepatitis B E antigen and E antibody test, is checking the viral load. And the viral load is measured by the hepatitis B DNA PCR. And this tells us how much virus is circulating in the blood when we sample it. And this also is used to try to help make decisions around treat now versus wait, in addition to these other markers. All right, so you may or may not have ever seen this type of chart before, but I find it quite useful to really try to break down the various interpretations of the screening tests, okay? So the screening tests, remember, are the hepatitis B surface antigen, the hepatitis B core antibody, and the hepatitis B surface antibody. What you have in the second column are the various interpretations, and then how you clinically should interpret the situation to be for a given patient. So let's say you check all three tests and all three of them come back negative. Well, that's a person who's potentially susceptible to hepatitis B infection. They don't have any marker for active infection, and they don't have any markers for immunity. So that's somebody who's potentially susceptible, and you should think about, is this somebody we should offer the hepatitis B vaccine to? So the next kind of panel of tests include somebody who's negative for surface antigen, but positive for both hepatitis B core and surface antibodies. So this is the point I was trying to make 2 slides prior, that certainly the presence of the surface antibody tells you that person is immune, but that alone doesn't tell us who's immune from the highly effective hepatitis B vaccine that we have available, or those who have been infected and then developed immunity, which again is more likely to happen for people who acquire this infection at an older age in life, right? Adult patients are more likely to kind of fit into this scenario who acquire this infection. So this, if the core antibody is positive, that's somebody who has had actual hepatitis B infection at some point. None of these tests tell us how long there's been infection been present. None of these tests tell us how long the hepatitis B has been in the system, and there's no test to tell us how you got this infection either. So the next test is scenario includes somebody who's negative to surface antigen and negative to core antibody and positive to surface antibody alone. So as I mentioned, if you're positive or reactive to the surface antibody, this means that you're immune to hepatitis B infection. So the distinguishing feature between the case above and this case is that the core antibody is negative. Okay, so if the core antibody is negative, this indicates that you're immune to hepatitis B due to vaccination. So this is how we help distinguish. You might see a patient who comes to you in your practice who says, "Doc, I've been immunized to hepatitis B, and they still meet, you don't have any lab values to review that were done to really confirm whether or not they received the vaccine, whether or not they've been screened." Um, in the case of UN, you still want to offer screening, right? Because she met criteria. We talked a little bit about in the first session how there's certainly cases of inappropriate hepatitis B vaccine in somebody who was never screened, who was in a risk category. So that should be the first step, really checking them for hepatitis B first. And so the way to distinguish between somebody who's been who's gained immunity from vaccination, which is this last scenario here, versus somebody who's been infected and lucky enough to clear it and developed immunity, is the presence of the core antibody. Okay, so that's a really important, and that's how you use that test in addition to the surface antibody to make that distinction. All right, so let's go through some additional scenarios. Let's say your surface antigen is positive, your hepatitis B core antibody is positive, and your IgM core antibody is also positive. Well, as I mentioned earlier in this talk, if the IgM to the core antibody is positive, that's a marker for acute infection. So somebody who's been infected within the last few weeks. And the further out you go from that time which you may have acquired the hepatitis B infection, this IgM will disappear. And some people will have the IgG that's positive early, or sometimes this only develops the total IgG after the core IgM has been lost. And again, this person is not immune because the hepatitis B surface antibody is negative. All right, the next scenario is somebody whose surface antigen is positive and their core antibody is positive, and the additional tests are negative. This is somebody who likely is in the chronic infected hepatitis B stage. Okay, now by definition, you have to have surface antigen present for at least 6 months to really meet the chronic definition. But we know, clinically speaking, if these two tests are positive, if you were to check a core IgM and that was negative, you're really in the chronic infection stage for these people. And the last scenario, which I think becomes a big hang up for a lot of providers, is what do we do if just the core antibody is positive and the surface antigen's negative and the surface antibody's negative? And this is actually a scenario in which we're going to take a deeper dive because Natalie was kind enough to submit a case that we're going to spend some time discussing at the end here. And that, as we're going to discuss, is a case in which somebody is core antibody positive alone, and we'll talk about the interpretation of the other tests. So there were actually 4 different ways to interpret this test. The most common scenario, like more than 90% of the time, is going to be that this person has resolved infection. Remember, if that core antibody is positive, it's a marker for most people having seen that infection and developed that antibody. Okay, so resolved infection is the most common scenario. The second interpretation is that this is a false positive, and so may still be susceptible. There are some additional tests you can do in this scenario, depending on the clinical situation. So some tests that you can order would include the E antigen and the E antibody test. And that, if either one of those are positive, that tells you that core antibody is real. That person has been exposed and infected with hepatitis B at some point in the past. And then there's this issue of what we call low-level chronic infection, or what we call really occult infection, which is exceedingly uncommon. And this is a scenario in which actually there hasn't been a lot of studies yet because of how rare it is. It's seen most commonly in people from high endemic areas, so East Asia and Sub-Saharan Africa, really people from that origin. And even within that, it's quite rare. And if you were to, you checked all the serologies, they don't have any marker for infection. But if you were to do something like a liver biopsy, you might actually stain some of the hepatitis B virus in the liver tissue. You can also check a Hep B DNA to make sure that there's none that you can detect in the system, and that should reassure you that the person doesn't have really active infection. And then finally, it can also be seen in the setting of resolving infection. So really, before you develop surface antibody, that marker for immunity, you might be catching it kind of in the window of somebody having just acquired the infection. Maybe if you were to check the IgM, that would be negative because you're more than a few weeks out from when they actually acquired it, but you haven't quite had enough time to develop the protective surface antibody. So this is a nice couple of slides to refer back to kind of help in an aid in your interpretation of screening tests. So feel free to come back to this, and we'll talk about this with respect to the case that Natalie submitted. All right, so now you found somebody who's surface antigen positive, and you want to know what additional tests to do. So we want to talk a little bit about lab tests for chronic hepatitis B infection. And so we talked a little bit about the additional hepatitis B specific markers we want to get in somebody who's surface antigen positive. Oftentimes we'll repeat it to make sure that it's in fact real. But the E antigen, E antibody, and the Hep B DNA test are the hepatitis B specific tests you want to obtain. And then you also want to get a sense of how the hepatitis B is impacting things in the liver. And in order to do that, because none of these tests by themselves tell us that information, you want to get certainly a serum ALT test, one of your liver enzyme tests, so you can order a hepatic panel or a comprehensive metabolic panel. And then you also want to think about how am I going to assess how much scarring, if any, to really understand what the status of the hepatitis B in this individual is. There are now some non-invasive markers of fibrosis. So there are biomarker tests, FibroSure, FibroTest. There are ways to calculate something called the FIB4, the OPRI test, which we're going to talk a little bit about it later on in the series. And then finally, really the last way to think about assessing for scarring, because that really helps us determine who needs treatment now and who can wait, is thinking about a liver biopsy. Now, before we had these non-invasive markers such as transient elastography or the biomarker tests, or really had validated the FIB4 and the OPRI scores, liver biopsy was really the only way we had to really assess for how much scarring there was. Scarring is measured on a scale of 0 to 4. And so the biopsy really is still seen as that window into what's really going on in the liver, but thankfully we now have some non-invasive ways to reliably do that as well and not subject patients to a liver biopsy. So we do liver biopsy a lot less commonly. And this also kind of allows for us to really discuss more hepatitis B management confidently in other non-specialty settings. So you don't have to always refer these patients depending on your confidence and comfort level to see a specialist. Because we have these non-invasive ways to measure fibrosis, we really can be managing hepatitis B more effectively from a primary care standpoint. All right, so then we think about kind of the clinical phases of hepatitis B. And I think this is an additional part of what makes serologies and how you interpret those serologies to what's going on with the patient somewhat of a barrier to providers feeling comfortable or confident around how to interpret these markers. So we just talked about these various tests. So the hepatitis B antigen, the E antibody, the Hep B DNA level, the ALT level, which is your liver enzyme test. And what you see here are kind of some of the older terminologies with the newer terminologies of phases of how we describe patients with hepatitis B. So if you look at kind of the time and years a person has an infection, and again, this often translates to years and age if you've acquired this at birth, right? But really in the first 20 years of infection, that's the period in which you're most likely to see somebody who's E antigen positive. And in the earliest kind of years of this, the first decade plus, you'll see a higher hepatitis B DNA viral load if you were to check it, and typically a normal ALT. Now, kind of some of the older terminology that we used to use included this term immune tolerant, and it wasn't really understood. What does that mean? There's tolerance from the immune system to hepatitis B? Well, yes, it kind of indicates that this is typically not somebody who needs to be treated now with antivirals, but because they're in an earlier phase of their infection, in which not a lot of damage has been done. But you really need the fibrosis assessment to make that call in addition to this. Over time, once you get to kind of the 20-year mark or plus, and again, none of our tests tell us with accuracy, aha, you're a patient who's had this infection for 16 years or 20 years, there's no test to tell us how much time. But these serologies kind of help give us a potential window into how much time may have elapsed. So what you see here is over time, then that E antigen titer typically comes down. And what you'll also see at that time is the Hep B DNA viral load come down and the ALT go up. And then as you progress a little further with having had this infection in the system for longer, you'll go on to develop E antibody. When you develop E antibody, you typically lose E antigen. It's a term what we call seroconversion. And then over time, what you'll often see is the Hep B DNA level, again, after cycling up and down along with the ALT, typically may come down. The terminology we used to call this was inactive carrier state. And I think that created a lot of confusion because it wasn't really telling us what do we need to do with this patient. And I think a lot of people interpret this to mean there's nothing that we need to do with this patient, and that's incorrect. They still need to be monitored, and this is somebody who's susceptible for developing fibrosis progression. And then finally, you can certainly have this reactivation phase where you might see the hepatitis B DNA going up and down along with the ALT being raised. And these are people who are at highest risk for developing fibrosis and at higher risk for developing liver cancer. So what you see here on this slide is kind of the older terminology for the different phases of infection of hepatitis B over time, and the updated terminology that's happened really in the last 1 to 2 years. So now immune tolerant is no longer, we now call it normal or minimal hepatitis, and I think this conveys a little bit more clinically meaningful information to a provider. So this is a stage in which there isn't really that much activity. There's still hepatitis or inflammation going on, but typically an earlier phase. This immune clearance has now been replaced with chronic hepatitis. Inactive carrier has now been replaced with normal or inactive hepatitis. And then really this reactivation phase is now been labeled as progressive fibrosis. And I think these terminologies are more meaningful. There's probably still yet more room for improvement for this to be more descriptive and easier for providers to understand. But certainly many providers, including those of us in the specialty world, are kind of happy to see that we've made these changes over time to try to make it a more descriptive term with these phases. Now, these phases just kind of give you a general idea of where this patient might be in their kind of natural history of this infection. It doesn't tell us by itself who needs treatment now and who can wait. As I mentioned, we also need some additional information, most importantly, some type of fibrosis assessment to tell us who's really progressing and in addition to these tests. And we'll talk about that in a couple of modules from now. Okay, so let's go back to our case scenario of UN. So she comes in for screening. You check the hepatitis B surface antigen, core antibody, and surface antibody test. And her surface antigen test is reactive or positive. So it'd be great to open this up for a little bit of discussion, and then I wanted to have some time to go into the case that Natalie also submitted. So her surface antigen is positive. So what are the next tests folks want to order on her? Do we have any volunteers? I see a lot of people on mute.
Yeah, feel free at this point to all the learners for these sort of more direct questions, feel free to unmute yourself and just address them directly.
So we just talked about kind of step one for screening is checking the surface antigen, the core antibody, and the surface antibody test. UN surface antigen test comes back positive. What are the next steps that folks would recommend for her?
So check the hepatitis B core and hepatitis B DNA levels.
Yep, so we want to check the Hep B DNA viral load. And what was the other test you mentioned?
I thought we can check the hepatitis B core, Hep B core, yeah.
Okay, so we've checked that as part of our screening labs, right? So we've checked surface antigen, core antibody, and surface antibody. And let's say either her surface antigen alone comes back positive or the surface antigen and the core antibody come back positive. So this patient has chronic infection.
Right.
And so as part of the next test, Sudesh, I think you mentioned you want to get the Hep B DNA. Are there additional tests you want to check on her?
Additional tests, I would definitely check for hepatitis C, HIV, and do an ultrasound scan, imaging of the liver.
Okay. So kind of part
liver
of your,
enzymes.
so you want to check her liver enzymes, right?
Right,
So I'm
right.
going to go back to one of these
Sorry.
slides here. You want to check her liver enzymes. You also want to check the other Hep B serologies. Actually, how about we go here? Sorry to jump around a little bit. So these are the additional Hep B serologies, the DNA, the E antigen, and the E antibody. And then you also want to check her liver enzymes, so the ALT test, some marker for fibrosis. Sudesh, I completely agree. Screening a person who's infected with hepatitis B for HIV and Hep C, this kind of relates to the first talk that we had actually, where we talked a little bit about how many people are co-infected with HIV and hepatitis B, that there are shared routes of transmission for HIV and Hep C and Hep B, and so it's important to screen all those people. And then anybody with a certainly elevated liver enzyme test, and at baseline, we typically recommend somebody who is a new diagnosis of Hep B to get some type of imaging test at baseline. Yeah. All right.
Yep.
So,
and it looks like Jenny included in the chat a response as well to that.
Thank you for alerting me to that. Yes, so Jenny, you're totally correct. Sorry, I missed that. The E antigen and the E antibody are part of the next test that you want to assess. So we talked a little bit about interpretation of those tests. And again, we're going to go over serologies again in the next session. And then in the fourth session, we're going to talk about how you put all of the serology results together and translate that into an action plan, a management plan for your patients by putting all of those tests together. And understanding the screening tests and these additional tests, as well as the various phases, help get us ready to talk about management a couple of sessions from now. All right, so I'm going to stop here, pause here for a second to see if there are any questions, and open it up to folks who might have questions about anything we covered. And in the meantime, I'm also going to bring up the case that Natalie was kind enough to submit. Are there any questions from anybody while we take a second here? Okay, so I think I'm going to be, here we go. Can you see my Word document? Okay. So Natalie, thanks again. I kind of copied and pasted some of the information that I was able to into a Word document so that we could all kind of look at it together. What I didn't include here were the repeat tests. So maybe you could help list them off, or I can pull them up on my computer here and just read them out loud. Do you want to take us through this case, Natalie? Or do you want me to walk us through?
Sure, yeah. No, this is fine.
Okay.
So, so I work with entering health sciences students who are required to submit documentation of a complete Hep B vaccine series and then a follow-up positive titer before they start patient care. And this was an entering student, 63-year-old Chinese American student who emailed me and said that she wasn't sure how to meet the requirement because she started receiving the vaccine 20 years ago when she learned her siblings were carriers, but then a provider told her to stop the vaccine because it wasn't necessary based on some lab test results that she received. And then she recalled that the provider continued ordering her liver function tests every year, but because there was a concern, then a few years ago they stopped ordering them and told her, well, you don't need to worry about it anymore, you're fine. I didn't have any further information about her, but she sent me her most recent lab report, which was from a few years ago, which you see here. She had a positive core antibody. She had a negative surface antibody, and then she had a negative surface antigen. So this is one of those ones that I hate to see because it was in that group of, on the chart that you showed where it said unclear what this could be, several
Right.
outcomes.
Right.
And so, and our infectious disease physician is out of town. So I felt like I needed to tell her what to do, and I wasn't sure what to tell her to do because I had several options I could do. So maybe others want to think through. I could, end up telling you what I did. I'm not sure if others want to discuss what they would have done.
Let's take a moment to pause here and discuss. So I think you mentioned a lot of things that are so common in day-to-day practice when we're seeing patients. We often are getting by verbal report, some of the history. Certainly one of my questions would, I'd be curious to know how many vaccines for hepatitis B she got 20 some years ago, just kind of more for curiosity's sake, not really for management's sake here. Did she share anything around that, Natalie?
Well, she had at least one dose, possibly
Okay.
two, but she did not complete the series.
Got it. So I think in the first session, we talked a little bit about the scenarios in which vaccines should be given and are not really helpful. And I'm gonna pull up the CDC frequently asked questions that you also sent our way in a moment. So this is somebody who basically is isolated core antibody positive. There's some suggestion, the surface antibody titer is detectable, but really it's below a level of immunity. Correct, Natalie?
Right. And I don't know if that's just the way this lab reports it. If there's, if I was taught negative is negative.
Yeah, so some labs will just report out reactive, non-reactive, or positive and negative, and some will, because they process this as really as a titer, they then give you how to interpret that value that they're giving you. So this is somebody who the surface antibody test really is not consistent with any level of immunity. There was a key part of the story or the patient's history that you shared, that you said that the siblings were carriers, right? So we know that worldwide mother-to-child transmission is the most common route of transmission that accounts for more than half of the cases, and or early childhood. So even if one child has mother-to-child transmission and the others don't, the others in the household are still at risk, right? So household contacts are recommended to be checked because there's still a risk of transmission. And if you do acquire that in an early childhood phase, you're at higher risk to develop chronic infection. So in anybody who's core antibody positive, I agree with whoever the provider was some odd years ago that they don't need to be getting hepatitis B vaccine. There's really no role for vaccinating somebody who's core antibody positive. The most common scenario in which that core antibody is isolated positive is what? How would you interpret the most common, 9 plus out of 10 cases when you see just an isolated core antibody test? How would we interpret that?
Well, somebody's been infected with hepatitis B disease. And right. I'm guessing that either the surface antigen hasn't become positive yet or the surface antibody hasn't become positive yet.
Right. So sometimes we don't know if somebody's in that window of resolving infection or developing chronic infection, right? And that's where the test results for the surface antigen and the surface antibody can be really helpful. So in this case, you're just looking at this one snapshot in time. If you just had to make one kind of clinical interpretation, the most common thing is that this person was infected at some point and didn't develop surface antibody immunity. The less common scenario is that you're catching this in the acute infection period. So it'd be really good to ask about any additional risks such as unprotected sexual intercourse, sexually transmitted infections. These things can still occur in foreign-born patients. And so it's important. And then the other things I ask about clinically is, did you have viral prodrome? Did you have jaundice? Did you have dark urine? Did you have any other symptoms that might make me think about acute infection period recently having passed? Now, a lot of people in the acute infection phase will not have any symptoms. So then you're left with, okay, yeah, the most common interpretation is, as I said, sorry, I can't toggle back and forth as easily to the slides. Would be that this person is immune because they've been infected before. But you had some additional questions, right, Natalie? So you wanted to really know what's the next best step for you to take in terms of counseling that person and also being confident that you understand really what's going on with the patient. So I think you laid out a couple of really thoughtful options here. Should you repeat the screening tests and then decide on your action plan? So do you want to repeat these to really help you distinguish what were your thought processes for potentially repeating the test?
Well, I thought first of all, you can always have a little bit of lab variability too. So I thought, this was several years old. I thought if she repeats it now, maybe she'll get the same results, but maybe the antigen will be positive this time. Maybe the surface antibody will be positive this time. And then I'll have I'll know for sure that she's the carrier or that she's developed natural immunity. And then she'll have met the Hep B requirement for entering students and she'll be done.
Yeah.
And won't have to do anything else. I can recall a student we had many, many years ago, and one of the providers I worked with chose to give the student a boosting dose of vaccine and then repeated the battery, and the student had a positive surface antibody. And with the thought being, well, the point of the immune memory response, if you come in contact with the disease or more vaccine, you would develop more surface antibody. So that's what I was thinking there. But I figured if I just start with telling her to repeat the tests now, I could see what her current state is and see if it matches or if it's changed.
And so I think that's great. I would love to open it up to hear what other folks think about this idea of repeating it now. Rita or Siddhesh? Do you have any thoughts on, the utility of repeating the test? Is that something that speaks to you?
I don't think repeating is going to be any helpful if it's done too soon.
Yeah, so timing is one thing to think about. I think we talked a little bit about that it takes time, right, for surface antigen to disappear, for surface antibody to appear. Now, these tests were done, Natalie, in 2016, right?
Right.
And you were seeing this patient last year?
No, a couple weeks ago.
A couple weeks ago. So sorry, I don't have the I couldn't remember if it was 2018 or 2019, the repeat test. Okay, so
3 years. I think.
So 3 years has passed. So knowing that information, would you repeat the test?
It can be repeated.
Okay.
So, from my point of view, I would just say if this test was done at the same lab, and then anywhere in the US it was done, and then I would say I would not do anything at this time because it indicates past infection coming from a high-risk area, which I would think is this patient was exposed as a child and siblings had the same problem or they were carriers. So I would think this was an old infection, which the patient was able to overcome this infection. And that's why the core is positive. And the surface antigen was negative. So there was no acute infection even at that time.
Okay.
So I don't think so there's going to be any benefit. At least that's what I think. I don't know.
Okay.
I have a question. When this was done 3 years ago, hepatitis surface antibody 3.8. I mean, that could be just she got the vaccine also, maybe 1 or 2 doses. If that could be, and then core antibody has no value. I mean, just a question.
The core antibody in this scenario is positive, though, right? So we talked a little bit about how to distinguish immunity from vaccine versus immunity from past infection.
It could be false positive.
It's pretty. I've never, to be honest, seen a surface antibody that's positive and having a false positive core antibody.
But this patient, I mean, this patient had vaccine also, 1 or 2 doses.
Right, but remember, this titer is not consistent with immunity, right?
But the
So
one dose of the vaccine will give people, I mean, will it give a consistent immunity?
So I'm going to talk a little bit about the CDC frequently asked questions, and I think it'll be helpful to send this out to the group. It's a nice resource, actually, Natalie had found, I think, in dealing with this case. You definitely have some immunity in somebody who's never been infected before. Key here, never been infected before after one vaccine. Okay, so so that's the key. You're here in this scenario, you're dealing with a very high risk person, right? This person is, they're Chinese American. We don't have any history about where the parents were born. Natalie, did you get that information when you saw this patient?
No, I mean,
Okay.
no.
And that's not uncommon. I think after now hearing the first session in this module, we may want to ask about where the parents are born, right? Because that
Right.
by itself puts you into an at-risk category for screening. But the important thing that Siddesh, you pointed out, was that this is somebody whose siblings have had infection. And so this is suggestive to me, right? If you have other first-degree relatives, particularly siblings or a parent, that this was somehow transmitted mother to child in those that were infected, or in kind of as an early childhood area as a household contact. And so you have other siblings here who are infected. So I think, as Siddesh mentioned, the core antibody being positive, the most likely interpretation, even if I didn't have any family history present, right? The 9+ out of 10 interpretation of an isolated core antibody that's really, that's positive here, is somebody who's been infected and resolved, okay, infection, and whether or not you have the surface antibody test result. And if you kind of add in then the family history, right, that there are some siblings who are infected, and that this person is Chinese American. So if we had the additional family, a parent's, birth country or origin country, that would be helpful. But you have enough information, as Siddesh said, to potentially stop here and just counsel this patient that you've been infected at some point in the past before. Your surface antigen is negative. There isn't any evidence of active infection. And I think this all kind of then comes back to what is the provider's level of confidence and comfort, and also kind of what the discussion is like with the patient, right? So, it wouldn't be uncommon for somebody to say, are you absolutely 100% sure, without certainty, sure that that's the interpretation of this test? Or maybe my level of putting all of these details together to understand that that's still the most common scenario, but I really, really want to be certain, may prompt me to do additional tests, and with repeating that battery now. And Natalie, you repeated the battery in this scenario, which I think is a very fine way to really be confident in terms of how to interpret these test results. And let me just pull them up. I won't be able to pull them up on the screen because I didn't put them into that Word document. But when you repeated it, that person's core antibody was still positive. Their surface antigen was still negative, and this time their surface antibody had a titer that was consistent with immunity. Correct?
Correct. Yeah, everything looked exactly the same,
Yep.
except for when she repeated the test 2 weeks ago, the surface antibody concentration now said it was something like 25 point something, so it's consistent with immunity.
Yeah, I have it in front of me, 18.8, so it was greater than 12.
Yeah.
So I actually want to pull up one other thing that you had sent my way, and I'm going to send this out. We'll have sent this out. Can you guys see the CDC document?
Not yet.
Okay.
The reason it was so important for this student is because she's choosing a healthcare career.
Yes.
And I think every time she gets a job, every time she enters a facility for training, and every time she gets a job at a facility, they're going to ask about her hepatitis B status in case of a bloodborne pathogen exposure. And so now she'll be able to have that lab report she can show them that says, I have immunity.
So luckily in this case, the surface antibody came up into an interpretation range of, immunity, right? This CDC guidance document, it's a really nice resource. So thanks for sharing it. You've highlighted a couple of sections for us to discuss here. And I think I'll start by saying one thing. There's one distinguishing feature between these cases, these two areas highlighted in yellow in your case, Natalie. Do you know what it was?
I'm not sure I understand what you're asking me.
So the core antibody in your case is positive, right?
Oh, right. Yes. Yeah.
And in these two highlighted sections, before we get into them, we don't know the core antibody status here, and I would actually assume that it's negative if it was known. And so that's one important distinguishing feature. So one important concept to understand is that in somebody who's core antibody positive, and your most common interpretation still at the end of the day is that this is somebody who's been infected and resolved infection because the surface antigen is no longer positive, is that they've already been infected. So there really isn't a role for vaccinating that person.
Right.
Most of the time, if somebody's been infected, will have a surface antibody that's positive. Either it'll say reactive or not reactive, positive or negative, or they'll give you that titer that they gave you in this case with something in the immunity range. Now, the couple of caveats to that. So this first area that you highlighted, the question is, at our facility, we do routine pre-employment hepatitis B surface antibody testing, regardless of whether the employee has documentation of a hepatitis B vaccine series, and consider those with a positive antibody to be immune. Is this the recommended strategy? So this is really only talking about the interpretation of having that surface antibody test, okay? And in those people, what they're saying, is this the recommended strategy? They say no. Healthcare provider with written documentation of receipt of a properly spaced 3-dose series of vaccine of hepatitis B and a positive hepatitis B surface antibody can be considered immune. So it's really important that you have those two things to really make that determination if that's the only information that you have available. Now, they also talk about antibody hepatitis B surface antibody testing of unvaccinated or incompletely vaccinated persons, and those without written documentation of vaccination is not recommended and is potentially misleading because hepatitis B surface antibody greater than or equal to 10 as a correlate of vaccine-induced protection has only been determined for persons who have completed a vaccination series. So they're really saying, make sure you have the documentation that somebody has had the 3-dose series. If you're hinging your decision on just having the hepatitis B surface antibody greater than or equal to 10, which it was on the second, but not on the first time, Natalie, in your case. But again, the very different feature here is that you're dealing with somebody who's core antibody positive. We're not just talking about how to interpret the surface antibody test alone.
Right.
Now, the second area that you highlighted here, the question, and I think I know we want to be cognizant of time and wrap up. An employee thinks she had 3 doses of hepatitis B vaccine in the past, but has no documentation of receiving these doses. We obtained a hepatitis B surface antibody titer, and the result was greater than 10. With this lab result, can't we assume she's immune? And while the answer is no, they do say a positive hepatitis B surface antibody indicates the vaccinated person is immune at the time the person was tested, but does not assure that the person has long-term immunity. So some people certainly at the kind of, when you're decades out from vaccination, or if at the time that you were vaccinated, you may have been immune compromised, or people with other comorbid conditions such as HIV, other liver disease, more advanced liver disease, all these things can cause you to not have as robust of a response to hepatitis B vaccine. Long-term immunity can only be demonstrated in people attaining an adequate hepatitis B surface antibody titer of at least 10 MIUs per ml after completing the full series. So these two scenarios, Natalie, really relate, I think, in the scenario, my interpretation of these FAQs was that this was not somebody who had core antibody positive, because that really changes what you do and what you can offer this patient. So I think the provider was right, whoever had seen her before, that these vaccination series is not something, that's recommended or worthwhile doing in somebody who's core antibody positive. The most likely interpretation, if I had no other ability to do additional testing of an isolated core antibody positive, would be that this person was infected in the past and is no longer currently with active infection. As Sadesh said, you might want to tie in some of the other additional clinical information. Or it's not a totally wrong strategy, though, to repeat the test. And Rita, as you mentioned, making sure that enough time has lapsed, right, in which you could really interpret the repeat results compared to the original results. So if you're only doing them within a week apart of each other, that might not be as helpful as, you know, in this scenario, you now are doing them, you know, quite some time apart. All right, I wanted to just, I know we're short on time here. We're really out of time, but before we do the confidence questions and the knowledge question again, are there any final questions?
I had a question
Yeah.
you know, with regards to the highlighted areas that I'm reading.
Mm-hmm.
So if it's not this institution, if somebody came as a hepatologist and talked to you and said, I have received 3 doses of vaccine, and then we do, you know, let's assume that the patient had this about 5 or 6 years ago, was vaccinated completely. And then we did the hepatitis B surface antibody titers, and they were more than 10. So, you know, my assumption is, or my practice has been, I would say, you know, you are adequately vaccinated. That's what I would say.
Right.
But I was just a bit confused looking at these highlighted areas.
Yeah, especially this first one.
Right.
So the CDC, I think, is going to still support the guidances that you have documentation of vaccine series to say somebody is immune from that route. I think what translates from what federal agencies put out as guidances and what we do in clinical practices, there can sometimes be a little bit of a mismatch. I would agree with you, Sadesh, in this scenario. If somebody is telling me that they're, I mean, I find it very uncommon to track down vaccine series documentation. I don't know about the rest of you guys,
right.
Let alone test results from 2016, Natalie. That's pretty amazing that your patient had that to give that to you, or you tracked them down. So yes, I think practically speaking, that surface antibody being either reactive, not reactive, reactive, positive, or in a titer, right, greater than or equal to 10 is very suggestive of having immunity. And a lot of times we're not, because of how fragmented our records are and you know, difficulty with having access to all of the healthcare information on our given patients. Practically speaking, I would counsel that patient that they're immune. Yeah.
Thank you.
Yeah, Kate, I know we're out of time, so I'm going to have you go ahead and launch the end discussion.
Great.
There.
No, thank you all. That was a very enlightening and helpful conversation, kind of exactly what we're hoping for with this ECHO HBV Bootcamp, is sort of a back and forth where we're all learning. So really appreciate the conversation, guys. As Dr. Perumalswami mentioned, I'm just going to launch 2 final polling questions. They're going to look very familiar as you interacted with them earlier. So now we're asking you again, how confident are you in interpreting hepatitis B serology, taking into account everything you've just heard and the discussion that we had? So again, are you feeling not confident, slightly confident, moderately confident, or highly confident? And I'll leave that up for about 10, 15 seconds. All right. Thank you, everybody, for your answers there. And our final polling question of today's module, which you've also seen already, is, I correctly distinguish between hepatitis B immune, protected, or infected status based on serology. Do you feel like you never, rarely, sometimes, often, or always are able to correctly distinguish? All right, I'll leave that up for about 5 to 10 more seconds. Perfect. Thank you again for all those responses. And it's looking like, you know, compared to earlier, people are appearing that they can correctly distinguish a bit better. So that's very exciting to see. It's sort of our goal, and also just briefly pulling up the confidence results, it looks like we're trending in the right direction as well. And again, to reiterate, next week we are going to be talking about serology in further detail. As Dr. Perumalswami highlighted, it is a very complex area, but we're very happy to see all the engagement. So the last things I sort of want to highlight is that if you look in your chat window, you should see a post-test link that I've sent. Furthermore, I believe Chris has been reaching out to you privately with the link. So please do engage with that post-test and evaluation. It really helps us know how the program is going and how you're all enjoying these lectures and things we might be able to improve on. Furthermore, you're going to be receiving a follow-up email from us tomorrow, which will also include that link. So if you don't have the time to do it now, you'll have another chance to access that test. We'll also be sending the slides from today's lecture from Module 1 if you missed it. And also we'll be including a video to Module 1. And the very final thing I would like to ask is there a volunteer who might like to present a case next week when we talk about serology part 2? Is there anyone at this juncture who might like to volunteer? All right. Well, we'll be reaching out if you do feel that something comes up, there's a case you realized. Feel free to reach out to any of us directly. We'll make sure you have all the case forms you need to get that filled out. But yeah, again, we really do encourage volunteers for case presentations. It helps foster these sort of back and forth, really engaging conversations. So please do, if you decide to volunteer, let us know, and we'll be reaching out to you as well to hopefully, nudge you in that direction a little bit. But we do understand. Does anybody have any final points they would like to make, either on the learner side or from you, Dr. Perumalswami?
No, I just want to say thanks. Feel free to reach out, and we'll be talking about serologies in a kind of another session next week. And thanks again to Natalie so much for submitting that case. I thought it was a nice discussion point.
Well, and this is Natalie. I want to apologize about the highlighted area. It actually it wasn't highlighted as a reference to this case. It's so that was really confusing.
That makes more sense.
It's highlighted. I keep that part highlighted for when I send it to students who question why they need to come up with documentation of their Hep B series, because in the past we always accepted a verbal history, but the CDC guideline changed several years ago, and then was reissued again in January of a year ago, that we no longer accept the verbal histories. And so I send that reference out quite a bit.
So Natalie, one thing we could talk about next week is, what do you do if the documentation can't be obtained? So we can talk about that next week as part of the serology discussion.
Great.
Okay.
Fantastic. Well, thank you all again to all of our learners, and to you, Dr. Perumalswami. We really appreciate your time today. Again, we'll be discussing serology part 2 next week. I'll be meeting at the same time, so that will be August 8th, 12 p.m. Eastern, but whatever time zone you may be joining from, the same time you joined us today, and we'll be sending up reminder appointments. Rachel will be sending a calendar appointment as well, so just keep your eyes peeled for that. With that all being said, we'd like to thank you again from Echo HBV Bootcamp, and really look forward to seeing you next week. Thank you all, everybody.
So long.